Okay, we have two more presenters and then the discussion period. The first presenter now is Ashley Gearhardt, who's an assistant professor of clinical psychology at University of Michigan. She developed the Yale food addiction scale, which I expect we're going to hear a great deal about for the next, this afternoon and tomorrow. And she did so to operationalize addictive-like eating behaviors, a way to measure them. She's currently directing the Food and Addiction Science and Treatment Lab to further evaluate whether an addictive-like mechanism contributes to certain types of problematic eating behavior. Ashley.
I want to start by thanking you all so much for inviting me here to speak with you today. I am truly honored to be included as one of the speakers, and I'm looking forward to sharing with you the data that we've collected with our goal of trying to examine, is there an addictive-like process that might be contributing to certain types of problematic eating? So I don't have any conflicts of interest to disclose. And so I want to start by thinking a little bit about why would we ever think that addiction might be playing a role in eating? What was the background that was set that made this idea plausible and start to take off in the early 2000s? And as we all know sitting here, that the obesity rates have continued to kind of skyrocket through the last few decades. And what's particularly kind of surprising is how motivated people are not to gain weight, how motivated people are to lose weight. The dieting industry is a multi-billion-dollar industry with people willing to get surgeries, only eat grapefruit, do pretty much anything under the sun to try and lose weight. And despite this high motivation, we find that most people fail. They might lose weight for a little while, but typically within 2 years, most people regain that weight. So what is contributing to this kind of chronic relapsing pattern where people are struggling to attain this goal? Additionally, clinically, there's been a greater acknowledgement that binge eating disorder is a verifiable mental health issue. And binge eating disorder looks at repetitive periods where people will lose control of their food consumption, consume objectively large amounts of food, and will be unable to control themselves despite a desire to do so. With this kind of coming more into the forefront, this became interesting because many of those phenotypes, many of the ways that binge eating looks as it presents clinically, it sounds a lot like what we see when someone's presenting with an addiction. They typically have lost control of their consumption. They show elevated cravings. They've tried repeatedly to cut down, and they keep failing. So these behavioral phenotypic similarities were quite interesting. And this was particularly of interest given that there are many common contributors to both binge eating and addiction-like disorders. So we know things like impulsivity, reward dysfunction, issues with depression, issues with emotion regulation. All of these factors seem to contribute to addiction as well as binge eating disorder. So this made us think, are there potentially common mechanisms that may be playing a role here? Additionally, you see that genetically, there's some suggestion that substance use disorders and binge eating disorder is maybe commonly heritable, especially in females. So genetically, we're seeing a lot of similarities. Mechanistically, we're seeing some potential overlap. And then there's some suggestion of neural mechanistic overlap. The brain really kind of has this reward system to ensure that we sought out what we needed to survive, that we got the food, the water, the sex that we needed to evolve and pass on our genes. And the common conception about what drugs of abuse do is that they are strong and potent enough that they can hijack that system and take all that reward and motivation and salience and start to attribute it to that addictive substance rather than to the things that you need to survive. And so the question is, we all need to eat, right? But it seems like with certain types of food, certain classes of food, people are eating in a way that's moving them past what they need to survive, and instead in a hedonically driven way, they've lost control of their eating, and they're doing it in a compulsive way. So all of these changes have occurred with a greater availability of ultra-processed foods. The food environment has been changing, where the foods that we have accessible to us in our environment are typically artificially high in fat, refined carbohydrates like sugar and salt. And the thing that was kind of interesting to me as I started to do this work and think more about this processed, ultra-processed foods is how really very different they are than what we evolved to eat. So I was trying to develop this stimulus set, and we were trying to think of foods that were naturally high in both fat and sugar. And there's pretty much none. The closest we've gotten is kind of coconut milk, has some a little bit, but just not that much. Foods are either higher in sugar, like fruits, or higher in fats, like nuts and meats, but those two things often don't come hand in hand. And so just the fact that the majority of the foods that we see in our food environment that are cheap, easily accessible, highly advertised, combine these high-level doses of sugar and fat and salt is evolutionarily novel. So our question has been, have some of these foods been changed in an addictive way? And so my lab has stepped back and said, how do we create any other addictive substance? There really isn't, there's maybe one addictive substance that occurs in nature, mushrooms. Pretty much everything else is the result of what humans create. You have to ferment the grapes, you have to refine and process the cocaine, or the coca leaf to make it cocaine. You have to take the tobacco leaf and refine it so it's a cigarette. And so when I look at our food supply and I think about what have we done in our food supply that's changed it, I would argue that we have changed it in many of the ways that we've created addictive substances in the past. And two of the major mechanisms that you do that through is by increasing the potency, the dose of something that's rewarding, and you increase its speed of absorption into the system, so you get a big spike. So if you think, for example, of the coca leaf. The coca leaf, when you chew it, you're not getting a very high dose, and you're not really getting this big spike into the system. And the levels of addiction to chewing a coca leaf is really quite low, even in places where this is a common culture occurrence, like in Latin America. In contrast, when you process it and you make it much more potent and increase its speed of absorption, it becomes much more addictive in the form of cocaine. When it gets processed even more, it becomes cheap, even more intense, you get crack cocaine, and you begin to see more and more of a spread of an addictive epidemic. So we kind of set this up like everyone needs to eat. But the foods that we see that people struggle with and that they lose control over and that really start to seem to hijack their experience is these foods that are ultra-processed, who have elevated potency and elevated speed of absorption into the system. And so our question is, have these foods changed in such a way that for certain individuals they may be capable of triggering an addictive response? So how would we identify addictive eaters? If you want to look at this hypothesis that some people are addicted to these ultra-processed foods, how do you identify who those people are? And so in the past, when I first started to do this work, there were a number of ways to do it that I felt had a number of limitations. So one was self-identification. Are you a carb craver? Are you a chocoholic? We don't really know what that means, especially given that addiction language is so common in the popular press. Can we feel confident that someone says, yes, I'm addicted to chocolate, is truly showing what we think of as an addiction response? Probably the most common way of thinking about whether or not someone might be addicted was by looking at their weight status. So if you're obese, you must be addicted to food, and if you're lean, you must not be. And we felt like there were a number of concerns with that. First, obesity has a lot of heterogeneity amongst it. It's a medical endpoint, and there's lots of different ways that you can end up there. You could have medication side effects, you could have a genetic concern, you could have physical inactivity, you could overconsume these foods, but not necessarily in a compulsive manner. If this is the case, if we say everyone who's obese is a food addict, we're likely over-identifying many people and taking this very heterogeneous condition and saying this is food addiction. Sometimes in my mind, I liken this to taking cirrhosis of the liver and saying that's what alcohol addiction looks like. There's going to be a lot of people who have cirrhosis of the liver who aren't addicted to alcohol, and there's going to be a lot of people who drink alcohol to excess in an addictive way who never develop cirrhosis of the liver. Additionally, when we think of food and saying if you have a normal BMI, you must have a healthy relationship with food, we don't know if that's necessarily supported as well. We think that's pretty likely to under-identify people that may be showing an intense relationship with food, but may not be obese yet, or may be in a situation where they're using things like purging or excessive exercise to mask their relationship with food so it doesn't show up in their BMI. So in summary, using body weight as the sole way to predict whether someone is showing an addictive-like eating pattern or not seem to both over and under-identify people. Perhaps closer is the idea of binge eating. So looking at individuals who show binge eating disorder, who show this pattern of consumption where they lose control, they continue use, they can't stop even though they want to. And so when we look at the way that binge eating disorder is typically defined and the way we define addiction, there's a lot of differences. So one thing is to have binge eating disorder, you must have this discrete period in a short period of time where you lose control over your food consumption and you know it, you're aware of it. If we use this kind of definition to describe cases of addiction, we would miss a lot. So first, there's things like cigarette smoking, where you have chain smoking. People never kind of have this discrete episodic binge, but they're kind of chronically and consistently using an addictive substance throughout the day. Alternatively, sometimes when someone's addicted to something, they may not be objectively aware that they have lost control. So requiring someone to say, yes, I felt like I was out of control at that moment, may again be missing what we typically think about with an addictive phenotype. And I think most importantly is that when we consider binge eating disorder and what are the theoretical underpinnings that exist out there right now for why it exists, the thought is that it's dietary restraint and shape and weight concern that are causing people to binge eat. So you're someone who being thin is very important to you, and you go on very rigid extreme diets to try and help yourself maintain and lose weight. You're unable to maintain that level of dietary restraint, you have abstinence violation, and you binge. And so the idea there is that you want to minimize the restraint around the eating behavior. You work to tell people there is no good food and there's no bad food. All food is game. In contrast, if we think of addiction, I don't know if we would really say there's no such thing as a good food or a bad food. I think we would probably say that if there is something where certain foods can trigger an addictive response, there's probably a range of kind of abuse potential within these foods, where some foods you can eat easily and you don't need to worry or moderate about. But some foods, saying, just eat this in moderation is much harder. I know coming home after a hard day at work, a bowl of strawberries doesn't quite have the same hedonic appeal as strawberry cheesecake ice cream from Ben & Jerry's. There seems to be a difference between these items. So the mechanisms and the treatments that come from these different ways of understanding binge eating from a traditional way and eating disorder and addiction are very different. So when I was in grad school, we looked to try and improve this level of specificity, and we decided to develop the Yale Food Addiction Scale. Our goal here was to think about how do we define any other addiction that exists right now. So I'm a clinical psychologist, and I treat people who have addictions to alcohol and heroin and cigarettes. And right now, if you walk into my office and I'm trying to distinguish, are you somebody who's a social drinker, or are you somebody who's actually addicted to alcohol? I ask about a shared set of diagnostic behavioral criteria. I ask about loss of control, I ask about tolerance, withdrawal, continued use despite negative consequences. How much of a experience in your life is this substance taking for you? And that's how anyone who wants to know right now whether they have an addiction or not, how we as a field decide. So that seemed like a pretty good place to start, is to take that same criteria we use for every other addiction to diagnose and see if that was even relevant to eating-related behavior. So our bank of questions were initially reviewed by addiction, obesity, and eating pathology experts, as well as binge eating patients. And this was to ensure that we were appropriately capturing the context and that it was clear to people who would be taking this sort of scale. We were kind of stuck in some ways between a rock and a hard place, because without a way to operationalize who might be showing an addictive-like response to food, it's kind of impossible to test whether some people are showing tolerance or withdrawal to certain foods. How are you going to know who might be showing that or not? So we kind of had to say, let's take our best guess at what we think tolerance and withdrawal might look like, develop this measure so we can operationalize those people, and then test those mechanisms. So the scale at this point has been validated in a non-clinical, clinical, and epidemiological samples. Here I have papers listed that I've been a part of, but it's been validated by a number of different labs independently for having both good psychometric properties and good validity. And it's also at this time available in 5 different languages, French, Turkish, German. I think a Spanish version just came out. So there's some other possibilities to consider when thinking about how do we define an addictive-like eater. If we want to test the hypothesis that addiction might be playing a role and we need to identify who those people are, what is the best way to do it? And so there's been alternative definitions that have been suggested. The DSM is not a perfect document, and it receives criticism, and it is currently in the process of being hotly debated, I think, in our world. But that being said, there isn't another standard of kind of agreed upon criteria that people use to say this is addiction. I think if I was creating this scale and kind of picking different criteria out of a hat that I thought meant addiction and then maybe cited the Dummy's Guide to Addiction, you'd all be all over me, I think. So in this instance, we really wanted to use, even though it isn't perfect, what is the most agreed upon definition of addiction as it exists in this field. And one of the things about this diagnostic criteria is that it has been applied successfully to a wide range of different disorders, behaviors, and substances. So if we conjure up in our mind what heroin addiction looks like, it looks a lot different than what we think about if someone's addicted to cigarettes. Heroin addiction is illegal. It's related a lot to being unable to actively be involved in society. You can't drive your car while you're using heroin, but cigarettes is a very different story. And for a long time, we started to focus on that cigarettes couldn't be addictive because they didn't look like heroin. They didn't look like alcohol. You could legally consume them. You didn't get intoxicated. You could watch your kids while you smoke cigarettes. But as the field has moved on and those arguments have kind of gone by the wayside, we've seen that cigarettes are potentially more addictive than heroin. They certainly kill more people in our society than something that looks as extreme as heroin. And we've used these diagnostic criteria to try and understand both of these disorders with some success. Alternatively, the idea has been to move away from behavioral indicators at this point and use neurobiological indicators as a way of identifying who may or may not be experiencing an addictive-like process to food. And I see this as potentially where the field is going. But at this point, especially with something as controversial as addictive-like eating, that doesn't seem feasible. Something that we know is addictive at this point, like alcohol, we are not at a point as a field where I can image someone's brain and identify whether they're addicted to alcohol or not. We're not at this level of specificity. Instead, in the field, we at this point rely on indicating through their behavioral phenotype who looks like they're addicted and who doesn't, and then looking at differences in the way their brain presents, their behavior presents, and the different mechanisms. So the strengths of the YFAS and the way that we conceptualize it is that it is a self-report questionnaire, and no self-report questionnaire is sufficient to answer whether there's an addictive process at play in problematic eating. Heck, there's not a self-report questionnaire that is sufficient to answer whether any mental health disorder exists, especially one as controversial and as complicated as problematic eating behavior. But we use this measure to identify individuals who may be experiencing an addictive-like response to food using the same basic behavioral phenotypes as all other addictive disorders. We didn't cherry pick. We didn't pick out some criteria that worked for us and some that didn't, but the same basic criteria. This is based on our current gold standard, although I'm sure that our current gold standard will change over time. Also importantly is nowhere on the scale does it say addiction anywhere. Because addiction is something that is so prevalent, the language in our society, that people will say, oh yes, I'm addicted to everything under the sun. We didn't want to prime that. And so we focus specifically on the behaviorals that we have seen to be indicative of other sorts of addictive disorders. And further, it moves beyond weight as a proxy. And this seems to be particularly important because some of the studies out there find that someone who's obese but not showing this compulsive binge eating type of behavior versus someone who is obese and shows very different mechanisms potentially. And so we want to say, it doesn't matter what the scale is showing you, we're more interested in your relationship with food and the behaviors that you represent. And the goal of this scale is not to say, look, we created a scale, so food addiction exists, we can all go home now, but to say, here's a measure that gives us the best chance of identifying who may or may not be reporting an addictive-like response to food. And what we are then tasked with is seeing, are the mechanisms that we would implicate in addiction and the correlates with what we would expect to see with an addictive-like response to food, are they present? And if we test that and gather the data and we find repeatedly that no, they're not, then we've answered the question. But if we do that and we say, look, here's this behavioral phenotype, it looks a lot like other addictions, and wow, a number of mechanisms are stacking up that suggest that an addictive process is at play, it changes the way we think about it. So I'd like to do just a quick, not fully conclusive review of the literature that's out there on the Yale Food Addiction Scale that we published in 2009, so about 5 years ago. So we found that individuals who have more addictive-like eating report higher current and lifetime BMIs overall. And what's interesting about this is that we found this even if the individuals didn't meet for any other sort of eating disorder. We actually found that if you looked at people who met for binge eating disorder only but didn't meet for food addiction, the food addiction only group had higher BMIs and higher lifetime BMIs, suggesting that this addictive-like eating, as you would suspect, would be related to higher body mass index. We've also found that individuals with higher addictive-like eating show greater risk for negative health outcomes, 2 to 3 times greater risk of hypertension, elevated cholesterol, and diabetes. Additionally, individuals with this greater addictive-like eating pattern show more severe binge eating. They have a tendency to binge eat more frequency, and overall show a more severe presentation of eating disordered pathology with more emotional-related overeating and restraint-related eating. We found that compared to BMI and restraint behavior, food addiction seems to be particularly related to elevated craving for certain foods, particularly foods that are high in fat. And we think this is important because in new iterations of the DSM and our thinking of addiction, craving is this key central component. And so again, if we were looking at addictive-like eating behavior and craving was not showing up, that would really be evidence against the idea that a common addictive process could be at play. We also found that individuals with more addictive-like eating showed higher emotion dysregulation generally, not just relevant to food. And we've started to look at this in children. And I think this is one of the most important potential outcomes about this work, is if we start to understand that certain foods are capable of triggering an addictive response, it's plausible that it would affect children much more than adults. Children's brains are more plastic. They haven't quite developed the same coping strategies as you do as an adult. Their reward striatal system is more reactive during adolescence compared to their executive control system. And kids are frequently targeted for marketing of unhealthy foods. They see approximately 6,000 food commercials a year, a little bit more if they're an adolescent. And almost all of those are for foods that we would suspect would be prone to an addictive process. So we find that in children who report higher levels of food addiction symptoms, those children have higher BMIs, show less satiety responsiveness, and exhibit higher emotional eating in response to emotions. Additionally, individuals with more addictive-like eating, regardless of their body mass index, show higher impulsivity scores and exhibit greater delayed discounting. Again, this is something that's very much related to addiction, where you kind of prioritize short-term reward over long-term consequences. So again, something behaviorally consistent with addiction. Others have found that there's an increased attentional bias for food cues, where the food cues themselves become more salient for individuals who report more addictive-like eating. And for individuals who report addictive-like eating prior to getting bariatric surgery, they report a greater risk of developing a substance use disorder after getting bariatric surgery. Potentially, some have suggested the result of a cross-addiction transfer. Others have found that individuals who have greater food addiction scores have a higher dopamine multilocus genetic profile score, so differences in dopamine signaling related to a different genotype, again related to addiction. And that they also show differential responses to dopamine agonist in the brain. And we found in the one study that's out there looking at addictive-like eating, patterns of neural response associated with addiction. So during anticipatory cues for food, we saw elevated activation in the caudate, the dorsolateral prefrontal cortex, the medial orbital frontal cortex, and the amygdala. And when people were starting to consume the food, we saw less activation in the lateral orbital frontal cortex, a brain region that's been implicated in cognitive control. One thing that we think is really interesting about our results is that when you think of addiction, what we see oftentimes is that the reward system stops really responding to non-addiction cues. So the reward system overall is hypo-responsive. And the only thing that kind of gets the reward system going once an addiction has developed is the addictive cue itself. So as Dr. Zayudin showed in his talk, we found that our addictive-like eaters were showing this hypoactive response to the other stimuli. But when they actually saw the milkshake cue, their neural response went up to a more normative level. And this is something that's consistent we see with other sorts of addictive disorders. I think for us, what was really surprising about this study when we first did it is that we controlled for body mass index in all of these analyses. So these are effects that occur above and beyond BMI. And we also have a restricted range of severity, as Dr. Zayudin pointed out. So what's surprising to us is we weren't expecting to find as many effects as we did, given the limited power that we had to detect changes. We had a large effect size across the board. And so what'll be important in the future is to look at this sort of research with more severe samples to see whether these findings hold up. Given the restricted range and the large effect sizes, there's some suggestion that it likely would. So what are next steps for looking into this construct? The DSM-5 has come out, so it's important to think about our changing understanding of addiction and to look at that and reflect the way we think about addictive-like eating. And also clinical interviews may be important. It's interesting at this point to think about how people may be interpreting these sorts of questions and whether more clinical specificity could come from doing a clinical interview. But most importantly, what's really relevant about evaluating whether or not the Yale Food Addiction Scale is a relevant and useful tool in our field is to replicate these existing findings and, importantly, to do more longitudinal prospective studies. This field is in its infancy. Like I said, we developed this scale about 5 years ago. So there's really no shock that there's lots of gaps in this literature. One would expect that. So what we need to do to really answer this question is to do research, to look at these hypotheses and test them. And if things come out negatively, where it doesn't seem like an addictive process is at play for those who report more addictive-like eating, that's really important for us to understand and know. We also are looking into testing more mechanisms. So now that we have a better sense of who might be the addictive-like eaters, now we can go in and behaviorally and biologically see, do they show signs of tolerance? Do they show signs of withdrawal? Again, tolerance and withdrawal have kind of come out of prominence. It used to be that addiction was kind of tolerance and withdrawal, and we've really moved away from that. But it's still relevant to the idea of addiction. So that's definitely an important mechanism to follow up. And probably what I think is most important is to identify what foods. At this point, I actually think that the term food addiction is a horrible misnomer. I don't think anyone who does this research thinks that everybody is getting addicted to like broccoli and kale or strawberries. It really seems to be a certain subclass of food that people report struggling with. And they're these foods that are processed and designed to be as hedonically rewarding and effective as possible. If we can start to understand that when people are struggling with overeating these, it isn't just that they're lacking willpower or they need to have more personal responsibility, but like things like cigarettes, these foods are potentially capable of triggering an addictive-like response. That brings up questions about what does it mean to live in our food environment? What does it mean to be from a lower socioeconomic neighborhood and only have access to those types of foods? What does it mean for schools to be able to make ends meet through the selling of those foods, or for children to be targeted specifically for the marketing of these maybe, possibly, potentially addictive foods? So understanding what foods, what in them, and why is an essential next step for us. And that will have incredibly important implications for the way that we currently treat and prevent obesity and eating disorders. There's a research that came out recently by Rebecca Poole and her group that was looking at the way that we frame obesity, the way that we explain it in our society. And if you look at our typical way of explaining obesity, that people kind of need to try harder and personal responsibility is where it's at, people stigmatize individuals who are obese very highly. They say, man, these people are just lazy and they need to get on it. But she also exposed half of her participants to the frame that these people were potentially experiencing an addictive-like response to foods, and it was triggering their body and their brain similar to the way that something like cigarettes would trigger somebody who's a smoker. And she found that people primed with that frame actually stigmatized obese individuals less and supported treatment for them more. So I think there's some potential possible gains if this research is found to be valid and true, view and the way we think, conceptualize, prevent, and treat obesity and related eating disorders. Which leads me to my pitch of I think it's very important to fund this research. It's a bit of a struggle doing this topic because it's controversial, and it's also kind of in the intersection of multiple funding bodies. And so we're going to, if we want to evaluate and test this hypothesis more, it will be important to fund large-scale, well-designed, rigorous studies to see whether these hypotheses hold up. That's how we're going to know whether this is true or not. And right now, the public perception is overwhelmingly that you can get addicted to overly processed foods. And studies of the public, it's usually around somewhere between 70 and 90% of people say, yes, I absolutely think that's true. Why wouldn't you? If this is not true, and people are already working under this misconception, it's important for us to have strong empirical data to say that that is not the case, so we can kind of leave that by the wayside. Or if we do find that it is the case, then I think it can encourage us to think outside the box about how to prevent or treat these eating-related problems. And so I want to do a thank you to Kelly Brownell and Will Corbin, who are co-authors on the scale and who I've worked with quite a bit. Other collaborators from different institutions that I've worked with on some of the research that you've seen here today. The Rudd Center for Food Policy and Obesity at Yale, who funded much of this early research. And a thank you to my lab, my students who are currently working on these projects. Thank you, and I'll actually take questions at the break.